Hi and welcome to part 3 of section 2, where we will cover upper extremities projection that consists of hand, wrist, radius ulna, elbow and humerus. So we start with the PA hand. If there is any rotation, the radiograph will visualize unequal soft tissue thickness and unequal midshaft concavity on the sides of the phalanges. However, the most common way to detect rotation is by evaluating the superimposition of metacarpal heads. The metacarpal head should not superimpose each other in a correct positional radiograph. Any flexed fingers will cause the joint space to be closed and foreshortening of the phalanges and metacarpal. The second projection of the hand is the oblique hand. To verify the accuracy of obliquity, evaluate the amount of metacarpal midshaft and metacarpal head superimposition. The hand should form an angle of approximately 45 degrees with the cassette plane. If the hand is positioned correctly, the first and second metacarpal head is not superimposed, while the third to fifth metacarpal head will be slightly superimposed. Next is wrist. To detect rotation in PA wrist, evaluate the carpal bones and metacarpal base. If the carpal bones and metacarpal base at the medial aspect of the wrist are superimposed, then the wrist is externally rotated. If the superimposition is at the lateral aspect of the wrist, then the wrist is internally rotated. Evaluate the scaphoid distortion. The wrist is flexed if the scaphoid is foreshortened and the wrist is extended if the scaphoid is elongated. In the lateral wrist, check the relationship between pisiform and the distal portion of the scaphoid. The wrist is externally rotated if the distal scaphoid is visualized posterior to the pisiform, and the wrist is internally rotated if the distal scaphoid is visualized anterior to the pisiform. Move on to the forearm. First, we have AP radius ulna. The evaluation of distal radius ulna rotation is the same as wrist, which is by evaluating the carpal and metacarpal bones. However, the detection of proximal radius ulnar rotation is different. It is done by evaluating the radial head and radial tuberosity superimposition with ulna. In lateral radius ulna, we need to verify if it is in true lateral positioning or not. Firstly, evaluate the distal portion of scaphoid, where it should projecting distal to and align with pisiform, similar to lateral wrist. Moreover, the capitulum and medial trochlea should be superimposed. The radial head and coronoid also should be superimposed. If the radial head is posterior to the coronoid, the humerus is elevated. If the radial head is anterior to the coronoid, then the humerus is lowered. Adjust the position accordingly to achieve true lateral positioning. Next is AP elbow. The elbow rotation detection is similar to the detection in proximal radius ulna, which is by evaluating the radial head and radial tuberosity superimposition of ulna. Meanwhile, to check for the elbow flexion, radiographer should assess the distortion of the proximal humeral or distal radius ulna. The part that is foreshortened is the part that is elevated. The lateral elbow assessment is similar to the lateral radius ulna that determines the elevation or lowering of the humerus through the position of radial head and coronoid. The last body part of the upper extremity is humerus. The humerus could be checked for its true AP by evaluating the position of greater tubercle, lesser tubercle, and humeral head. In true AP, the greater tubercle is in profile laterally, while the lesser tubercle is located halfway between the greater tubercle and humeral head. In addition, the humeral rotation also can be assessed by evaluating the radial head and radial tuberosity superimposition of the ulna. Lastly is lateral humerus. Radiographer should evaluate the radial head and coronoid relationship in order to verify the accuracy of lateral humerus positioning. Radial head that is located anterior to the coronoid indicates mediolateral projection. The superimposition of radial head and coronoid indicate lateral medial projection.